to hearing our great presentation today. So let's see. So our agenda today, we're going to hear from Tristan Dinkle with the Rett Syndrome Clinic about what do they see, vision, and Rett syndrome. This is something that we often talk about in CDKL5 deficiency disorder, but is not often talked about in Rett syndrome, but is something that we should learn more about and start thinking about in our children as the research is coming. After Tristan concludes with her slides, I'm going to give you a few updates from rettsyndrome.org, and then we'll move on to QA. Now, we at rettsyndrome.org believe that all information should be made available at no charge to all who avail themselves to it. And we want to make a special thank you to our educational program sponsors, Acadia Pharmaceuticals, Greenwich Biosciences, Neuron Pharmaceuticals, and Novartis. Especially in this year, we really appreciate their support for our educational programming, which allows all of the wonderful dollars that you all have continued to raise in this unusual year through virtual strollathons, virtual galas, your birthday pages, Giving Tuesday. It allows us to direct those dollars to research, which, although it hasn't been as smooth as we had hoped this year, has continued. So I'll give you some of those updates shortly. On behalf of our board of directors, myself, our virtual team, and all of our volunteer state reps, we really appreciate your commitment to your children, and we hope that this presentation will get you recentered and refocused on some things that you can work on in this time, even if you are just starting to pay attention to this in your home, and especially as you're going through telehealth, teletherapy, perhaps remote learning. These are things that you should let your providers know about. So without further ado, what I would like to do is pull up these slides, and I'd like to get going on our presentation because Tristan has some wonderful information to share with you. So Tristan, if I can invite you to please pull up your webcam and introduce yourself. Hi there, welcome and happy holidays. Thanks for being with us.
Hey guys, I'm excited to come down in my dining room today so that I can have my Christmas tree join us today since we're here for the holidays. So I just wanted to thank you all for taking time out of your holiday season to be a part of this and listen in if you're not doing this live, but doing it at a later time, or inviting your team to be a part of it. I know that this is it's just an important topic that everyone should partake in at some point to just consider what we have to talk about today. So I just want to piece this down here so I can make this bigger. There we go. I think, so I'm just going to talk a little bit about me so you can know my background here. So I'm Tristen. I am the nurse coordinator at the Rett Clinic here at Children's Hospital in Denver. I've been the nurse coordinator here for, I think it's been 7 years now that I've been working over here running this Rett program. I also run the Batten and Neurodegenerative Disease program here at Children's Hospital. And on the backside of that, I've done neurology and neuro nursing here for 12 years at Children's in a children's capacity. And so neuro type things have been my background period. And then I'm getting my master's currently in palliative care. So that is my general background, and today we just want to talk about vision and cortical vision impairment in Rett syndrome. It's going to be a broad presentation talking about cortical vision, but also just vision in general, things that are really practical things that you can be doing at home, in therapies, at school, kind of everywhere. So even if you're like, you know what, I don't know if my kid has full cortical vision impairment, there's just some things that you can be doing to slow down, look at the environment that your child is interacting with to better utilize their vision in their whole environment. And I think everyone can walk away with something that they can change in their environment today to help their child interact and see better. All right, let's move on. I have no disclosures. My joke is I'm always up for more money, as we all are, right? All right. Go to our next one. And my goals are just to talk about vision and Rett syndrome. What is cortical vision impairment? How does CVI fit into Rett syndrome? How do you diagnose CVI? And living and interacting with CVI. So we'll keep going here. Thank you, Paige, for being my assistant today. So vision and Rett syndrome. You know, when you look into research or what have we looked at in Rett syndrome with vision, there hasn't been a lot of research done on Rett at this point. A lot of it, it's just the barrier of when you do an eye exam, is you need that interaction of, as we've all had eye exams, and you go, click, click, how much do you see now? Click, click, how do you see now? Click, click, how do you see now? But it's hard. It's hard when you can't have that verbal acclamation of how much can you see with this. They've tried doing, and I have put at the end some references for you to look at if you'd like to, but there's been some different testing done. We've tried doing evoked potential, some different tests to try to see what they're seeing. And I'll show you in a few slides the barriers to that, where the problems are occurring in the fact that our eye is seeing something. It has to go all the way back into our brain, be processed in the back of the brain, and then be sent to the different parts of our brain to process what your eye is seeing. And that's where we're coming into problems, because your different neurons in your brain are having to send all that different information everywhere. And it makes sense that when your brain is having to send different pieces to different parts of your brain, that there could be some problems with that. We hear both ends of the spectrum. When you look at clinically, what are we seeing? Research-wise, we're not seeing a lot being produced of saying what we're seeing in these patients. If I say kiddos, I know that we have all ages tuning in today, or that we see all ages in our patient population, but I might say kiddos today, and I don't mean kids or adults, I'm just saying all ages. But that might be my term that I use today, is kiddos. I just, sometimes patients seems a little clinical for me, and I just know that that's what I might say. We hear both ends on the spectrum. We might hear that some people feel like they have really extreme use of their eyes, that they're having that real visual fixation where they're really strongly looking at you and being able to look at things. But then we also hear the other end where someone, I'm going to use a lot of things where I hold up to the camera today, and it just might happen. I'm a very visual person in terms of using visual proxies. But you might have a lot of people say, well, when we hold it up, they don't look at it. And that's where we might hear some of these things. So we might hear very far ends of the spectrum when we talk about vision, is that one end might be like, well, they have this strong look when they look at people. And then other people might be like, yeah, but you know, they're staring off this direction, or when we come into a room, all they do is stare at the light. So that's, you know, clinically kind of where we see a lot of things. Or some people might be like, well, they kind of look at you, but they might look through you. Or if there's a lot going on, they kind of just close their eyes and shut down. So I'm just kind of talking through some of the things we see clinically in our clinic. And again, not a lot of the research, I have things listed. what we recommend, and I'm also including some of the questions I got here from you guys beforehand. Vision exam wise, we do recommend these yearly for life, is going and getting those vision exams. And some people are like, well, they don't tolerate it when we go, or we don't want to get glasses. And that's okay. My biggest thing is I tell people is they're like, well, we're not going to give them glasses, so what's the purpose of going? The main purpose of going is always the actual health of the eyeball. And that's the whole age of life, is that as they age, we're still seeing people get cataracts and things like that, where we're wanting to actually look at the cornea and the actual health of the eye. So whether that's you're taking them to the ophthalmologist and they're actually doing a full examination, or you're taking them to their pediatrician, and the pediatrician is actually just looking at their eye and able to look fully into the eyeball and go, okay, you know what, the back of the eye looks healthy and the eye looks healthy. Or taking them to the ophthalmologist and saying, you know what, we don't want to get glasses, but we do want to make sure the eye and the back of the eye and there everywhere in the eye that is healthy. And that's the part that is the most important part, is that all that kind of stuff can age just like everyone else, is that they can still have those kinds of issues. And then we want to watch the normal things that can happen, even if you aren't pursuing glasses. And some people are saying, well, is it really important that we get glasses, or that they have glasses that have the reading parts, or all these different pieces? And that's the part that is up to your discretion. Some people want to get glasses, some people they're hitting the glasses, or with their hand stereotypies is that they're not tolerating the glasses because they're hitting them or they're rubbing them or doing different things. And that's okay. Glasses are to your discretion or to their comfort, because sometimes if they don't have glasses, they can get headaches, and those can be a whole another level of pain, or things that are causing discomfort or crying sessions. Someone else asked about that. And that can be due to headaches or something that, you know, with their vision, they're getting headaches, and could be another reason of behind things. So just keep that in the back of your head. We can move on to the next thing. So what is cortical vision impairment? So it is the leading cause of visual impairment in kids. The issue of what is causing this is that, you know, in developing countries and our type of countries, such as here, our kids are being born earlier and earlier and surviving at earlier ages. And so we have a lot of brain issues that are surviving, and our brains aren't, it's a brain-based visual vision, if that makes sense. So our brain, if you, can I take control? I hope you can see my little cursor here. But what's happening is through our eyes, our vision is coming in, and it's going all the way to the back of this occipital lobe in the back of the brain. I don't know if you can see my little cursor, but I'm hoping, there we go. So the occipital brain there, to the back of the lobe. And it's really caused by the eyes and the brain not communicating as they should be. And then when the information comes to the back of the occipital brain, it can go through two different visual streams, either through the dorsal stream that goes up through the top of the brain to the parietal lobe, or it can go up through the ventral stream that goes through the temporal lobe right here. Up through this ventral lobe is the portion that helps you understand, so the ventral right there. So that's the who are you? What is it when you're interacting with the world? Like, that's me understanding, oh, this is a pen. That's who are you? Oh, that's my mom. Okay. When you go up through this dorsal visual stream, that's when you're going through the world and you're going, okay, where am I moving? Where am I? Where are you in my environment? So you're having the brain interacting with multiple parts of the brain when it sees something. It comes into the occipital brain and then it goes out into the different parts of the brain. And so those neurons have to be able to process things well. And when we're missing and we have MECP2 that isn't working as it should be properly, you can see how, or if we have other people tuning in here that have other pieces of genes that are not working as they should be, you could see how there's pieces that make it difficult for your eyes to interact with your brain in a way that it should be, and make it hard for your eyes could be seeing 20/20 and be working just perfectly. But the problem is that your brain isn't working as it should be to interact and process what it's seeing out in the world. And so I think that's the hard part, is that there's a lot of places for that signal to be interrupted as it's coming in and then going out into the brain. Let's keep going. There we go. And the causes of that could be Rett syndrome, could be CDKL5 deficiency disorder. And I know that some kiddos in here could have multiple wrong causes, or premature bleeds, strokes, hydrocephalus, trauma, just general structure issues. There could be other parts of the brain that are missing, or neurological issues in general can cause. So having seizures puts you at risk for CVI as well, and things like that, because again, that's interrupting the flow of those pulses and those things going out in the neurons throughout the brain. And at this time, the incidence is really unknown. It's rising in terms of diagnosis, mostly because parents are awesome, and because education is, and parents are becoming better advocates and saying, you know what, I think my kid has this, and going out and getting diagnoses. But let's keep going. How's it diagnosed? One is someone having a history of a neurological events, that their examination doesn't fit how they see or they use their vision. That when we say, you know what, they have a 20/20 vision, but when we go to show them something, they're not looking at it the right way. That they have presence of some of the 10 things listed on the next slides that we'll talk about. They may have a normal eye exam, that they've used the visual evoked potentials, and it shows that they're not using their vision as they should be. An MRI may show a normal brain, or that may show that they have brain issues, either one. And then a CVI range tool that CVI specialists have. Continue on. I'm just going to talk through the behaviors of CVI and what we look for. Okay, so, and these are just things that help us know how to diagnose CVI, but also ways to help treat it, and ways you can make changes in your environment to help a child interact with their environment in a better way, to visually, to use their vision and help their brain interact with things in a way that help them do better, if that makes sense. So one thing is color. These children might have an unusual attention to certain colors. And one thing is red and yellow, and that's just because for some reason the brain can see those things better. Black and white might be a little bit harder for them to see. And one thing is that this red and yellow is easier for them to see. And so one thing we've done in our clinic is we have like these set of stairs that we always test patients on and have them go do the stairs. The problem is that we'll have patients go do these stairs and they pause on them. And I was seeing that they were pausing so often when they were trying to come down, and they would kind of go to take a step, go to take a step. And I realized, you know what? I don't think this kiddo can see. And she would just kind of pause, and I don't think she could see it. So what I did was I took, this is orange, my kids took my red tape, but I just took some this is washi tape, but you could take some washi tape. You could take some like, the kind I used was like an electrical tape we had around clinic that was red. And I put it along the lines of each step. And you could do that in your house. You could do that in places. Someone asked about a swimming pool and said, you know, when my kid goes to step in a swimming pool, they couldn't see it very well. And it could be that they're not seeing it very well. And one thing could be using something of color, whether it's, you know, you use a folder, or you use a tube at the pool, something of color that they can see better. It could be, this is why some kids are really drawn. You'll find that a lot of kids with visual issues are really drawn to Elmo because of this reason. You'll find that a lot of kids are drawn to a certain toy of a color that they see well, and that could be for this reason, that they can see those things. So a few other ideas that you might have is, once you find the colors that your kid can see really well, is wanting to use that to your advantage. So you might want to wrap it around, I've heard families going around a light switch, and again using tape and putting it around the light switch, and so that the kids can either hit it to turn the light switch on and off, or using, you know, Dr. Binky has one of those on and off buttons, or those buzzers, and his buzzer is red, so that if you're wanting to get an answer out of someone, you can have them push that button that's red. The other idea is, if you're wanting them their cup, and their cups, as you can see with this picture, they're using dining set that's colored that. But if you just have your regular cup, taking something that you can wrap around it and making it so that they can find it a little bit easier, whether that's a plastic wristband, whether it's one of these doohickey things, I can't think of the word, or if you're working on doing your augmentative communication, I'll show you a little further down, but doing those things in certain colors, again, to make it a little bit easier for them to see it. The purpose of this talk, besides talking about CVI, is also just to make things a little bit easier. And if that just means using simple things, such as changing the colors to make it easier for them to see it, that's what I'm looking for today. Let's go on to the next one. Movement. So these kiddos, if I just went to hold, I need to stop using the pen. So if I went to hold some, this is a dog toy, but it was my red thing I could find. If we're going to show them something, sometimes if I just went to show them something like this, they couldn't find it. But as soon as I go like this, they're like, oh, there it is, I found it. And it's because you add that movement. A pinwheel, it's shiny and it's moving. We use the pinwheels a lot in our clinic, because you can also test seizures with it. But you can also, it's shiny and it's moving. And so it really adds in that movement factor. But sometimes that pure just sitting there and you just show them, and you know, don't wear a kid out, but later just try some of these things. See, test, just see what things work for them. See, and I'm going to talk through a lot of things today, but just see and see what kind of things are helpful for your kid. But one of the things is showing them something, and then just try the movement. See if, you know what, oh, they found it a little bit faster if I moved it when I was trying to say, hey, do you want this or did you want this? And then you move them and see which one did they find that they wanted. Go ahead into the next one. So latency, I think this is the biggest tip I can give you. And if you could walk away with this to anything today, is that the world moves fast and they can't keep up. And part of it is that again, that going from their eye to their brain and going out into the places in their brain it needs to be processed, takes longer. Those neurons are a little bit slower. And so when we're asking them, and this happens all the time, I see this with our therapist, is the therapist will show them something, wanting a response, wanting to ask them to hit something, touch something, respond to something, or do something on the Toby, or wanting to generally hit something, but they don't give them enough time. And the latency period, meaning how long it takes them to do something, is longer for these kiddos, and it takes them a longer period to look at something. And the problem is that we move something in and out of their vision before they've had a chance to look at it, and that their brain takes longer to process what they saw and what they need to do. And so the problem is we'll put it in their vision and be like, hey, do you want this? Touch it if you want it, or whatever we're asking them to do. And we'll put it in their vision, and then we take it out, and then they're like, oh, what? Or I'll come over. I do this all the time, and I've really been working on it, is I'm coming over to say hi to them, and I'll come over and be like, hi, blah, 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 blah. And then I walk away before I've given them a time to come over and look at me. And that's terrible, because their brain is still going, oh, we heard a voice, we heard a voice, find where that person is. And I've already left their vision. I've already left where they were trying to find me. And that's where we need to slow down and advocate for our kids and say, you know what, it takes them a little bit longer to try to find you. Could you give them a second to try to find it? Or, you know what, could you just stay there for a second and let her try to find you in her vision? Because sometimes if you notice, these kids, it just takes them a little bit longer, you know, and it's not that long. It's just that the world moves so fast. And so we'll show something and we just move it, and we're trying to move along in our examination, or we're trying to move along in feeding them. Even you're putting a spoon in front of their face and you're like, okay, let's take a bite. And then they're not, and then you're like shoving it in, or we're taking it away, or oh, they didn't want it, when really they might have wanted it. But again, they didn't have time to go, oh, food's coming, let me find it. Oh, it's gone. Guess I didn't get it. And I think it's that little stuff that if we just pause a little bit longer, the food's still here. Do you want it? It's still over here. Do you want it? And just waiting. And I know it's hard, and it takes this like visual, this like mental cue to like slow down and slow down. And I think that is just my biggest, and I'm spending a long time on this, but I know that's the hardest thing, is just to pause on that. Okay, let's keep going. Complexity. How many of you guys, I know I can't see you, but how many of you walked into a classroom or seen a classroom that looks like this? Me, I know. It's so busy, and their brains have a harder time making sense of things on a busy background. And so going into a classroom or sitting in a room that has so many things going on like this, it's hard for their eyes to pick out one object next to another. They all blend in. They can't use their, and even in these classrooms, you know how loud they are. It's hard for them to use their vision if there's a lot of sound. So I think the problem too is they go into the classrooms, if they're still in a classroom, or they go into a place like Target with you, they're running errands, or they're at home and the TV's on and people are, you know, siblings are going crazy and all this stuff's going on. I'm just trying to give different instances here, but it's hard for them to use their vision if there's a lot of sound going on, because again, their brain is working extra hard to try to send this, I'm just going to keep going, the signal from here to here to here, if all this other stuff is being processed, because their ears are trying to process things and everything's, and then their eyes are also processing everything else in this. So just keep that in mind when is remembering that the complexity for them is just a little bit harder. The other idea is to remember positioning. You know, a lot of kids with Rett are sitting in wheelchairs. And so it's easy to remember to check their positioning. But even that is another factor that if they're slouching, kids are sitting any which way, it's hard for them, again, to focus one way if they got different things sitting. So just to remember to keep their feet, I'm not even doing this right now, feet down, back against the chair, and good body mechanics so that everything's kind of going, that if they're trying to do a therapy or they're trying to do schoolwork at this time, or you're trying to even get them to eat or do something that you're trying to get them to focus and do what you're trying to get them to do, that everything else, the TV's off, the sound is off, things are kind of down and low stimuli so that they can use their vision to do what you need them to do, whether that's to watch while you're bringing the food in, whether it's to watch while you're trying to get them to respond to their Toby, just different things like that. Just to remember that this complexity measure, that all that stuff, if it's too busy, it's harder for them. Let's go to the next one. So visual field differences. Oh, go back. I think we missed one. There we go. So this is typical is that they will turn their head to see things, and that the visual field, you know, a lot of them will have issues with CVI with having the lower field is, so when someone was saying they were having problems going into the pool, and even this kiddo that we had going down the stairs can be hard for some of these kiddos. And that would be a symptom of CVI, is that if going down the stairs, they're kind of stepping, it's because they can't see it and they're using their feet to kind of feel for what they can't see. And again, putting the tape or doing things like that might be helpful. The other thing is that they will often see is that if they want to see something and I put it out here, I'll see a kid go like this. And those are kids that have a different field that see things out of this, you know, they're looking here, but they look over here to see it, or they'll see it over here, and that's the best place for them to see things. Sometimes you show kids things here. That's very often where you'll often place things and go, oh, here, let's show them things here. Even shake it. It's even red. I'm doing all the things right. But for some reason, they're not looking at it. Try different areas. Try things up here. Try things up here. Try them all around. It's very often that kids will do this eye thing or even look straight ahead, and then they find it and you see them grab it. You'll see them grab when it's right there. But if you put it right here, no grab. Put it right here, oh, grab every time. Put it over here, grab every time. Straight ahead, they don't see it. And some kids just have different visual fields that they can see better when it's here, they don't see it here. And I think it's a very common symptom of CPI, is just having different fields where they can see things. And that's just a different thing. And a lot of them miss that very bottom, and have to either turn their head down, turn it up. They have just different ways of seeing out of their eyes. Keep going. So visual novelty. We are wired to notice new things. Our brain notices it immediately. I always use this, and I'm probably not aging myself, but kind of. And eventually I might have to come up with like a new thing. But if Elvis was to like walk on my screen right here, you would immediately notice it. But everything in my room right here, you like know that this is a Christmas tree, you know this is some decor and some trees and a lamp right here. But to them, everything right here is new. Everything is new in this room. The other problem is that it's all kind of a kaleidoscope vision. So it kind of all looks hodgepodgey. And so it can be kind of like this vision where it all kind of looks new and it all looks mixed. And so they prefer something they've seen before. I think the best way to describe this is using, if this is, sorry, Dr. Way, but if Elmo is something they love, they've seen before, is using those kinds of things for their therapies, is using things that they're familiar with, they've used, they've seen before, and surrounding, you know, their room is a great place to say, you know what, keeping their, I think sometimes our parents will be like, well, you know, we redecorated or we did this, and I think that's sometimes almost a scary thing. Or even coming into our clinic can be a scary thing because we have all these decorations, we have all these things, or even into the hospital, we change for the seasons. And sometimes that can be a scary thing for a patient, and acknowledging, you know what, we're going to come into the hospital and I think they've decorated for the holidays, so know that it looks a little different than normally when we walk in here. And just giving them those cues that it's a little bit different today than it normally is, or talking through some of that stuff, because sometimes that visually is very scary for them. And by the time you've already made it to your visit of wherever you're going, they've been so visually stimulated by everything they've seen that's different than what they're normally seeing going into a hospital. They're exhausted. Their brain has already processed a million things they're not used to seeing. And now they get to this room and they're like ready for a nap. And you're like, and why are they already ready for a nap? We just got here. But their poor brains have already been like, oh, what was that? What was that? What was that? We haven't seen that before. What was that? And trying to piece through like all the things they've taken in. And so just thinking through, you know, the way they process things and how they see things. Let's go on to the next thing. A reflex response. This is something we often see. You know, we'll have patients come in and we'll say, okay, you know, how do you think your child sees? And they're like, oh, I think their vision is pretty good. And then, you know, one thing we'll do is we'll, you know, touch something to their nose. And this is something that patients with CVI will be missing, is they'll have a reflex response that is missing or delayed. What's typical is that when you touch something to their nose or bring a hand up to your face, is that you're going to blink, you're going to protect your eyes. And one thing is that they'll be missing this, or it'll be absent, or it'll be delayed. You'll bring something up and then there's no blink, there's no nothing, because they didn't see that coming, and their eyes have that delayed. Again, their eyes might see it, but the brain is not processing the fact that something came up to their eye and they didn't close it. And again, this can be a really dangerous thing to lack this, and a reason to work on getting things in place to treat their CVI in a way that helps them work on this fact, because it can be dangerous, and having things come at your eye and not closing your eye in time is a dangerous thing. So let's move to the next thing. So distance viewing. I think someone asked me about this, is that if something's too far away, they're not going to see it. And like here on this visual, is that if it's too far away, it all just becomes mixed in the background. It looks like a blur of things. And they need it near, not because, again, their vision is bad. They might have 20/20 vision, but when it's closer, they're able to distinct this from this. They're able to say, oh, that's a dog toy, and this is a thing of tape. It's not all in the background here, just a blur of things, of colors and things. But when it's closer and in the correct field of wherever they can see things best, they're able to simplify it and see what's what, and see which things are which, if that makes sense. So let's keep going. So light casing. I know many, many families, this is probably the most reported thing we get from families is that when they go into a room, their child will stare at either the lights in the ceiling or at the window. You know, in infants where they see CVI, you know, it's usual that when there's a light that they will close their eyes, but these kiddos will open their eyes to the light. And generally these kids just need more light to see something. And so what they will do is use this to your advantage with CPI and use these light boxes. If you can see where they're using this, they're using educational things or whatever. You could put your meals on these light boxes. These are things that a therapist could get for you, but you could put meals on there, you could put learning items on there, you could put their whatever they're using. This can sit right on their tray for their wheelchair. This can sit right on the table when you're trying to give them a meal. This can be used to your advantage. You can change the light on their Toby to be bright. You know, you can use this to your advantage if they do like the light, but staring at the lights in the ceiling, even better if there's a fan going, because again, there's that movement. But this is a typical thing that we see with a lot of the patients, is that they will stare at the lights, particularly in the windows as well. So, but you can use it to the therapist's advantage as well. So let's move to the next one. Absence of visually directed reach. So what we'll do, you'll see is, I'm going to move my camera down just for a second, is you'll see a patient, you'll see them close their eyes and they'll look at the item and then they'll look away and grab it. And that's called not looking while you reach. And what they're doing is, because it requires multiple parts of the brain for you to look at something and grab it. You're having to use motor things and your visual. So if they close their eyes, they're able to focus just the motor to grab it. But first, they look at it to clock it. Where is it in my space? And what is it? And then they close their eyes and they may look away, or they just close their eyes, and then they grab it. And that's a very typical thing as well, that their brain has too much going on that they can't just grab it without closing their eyes. Again, it's just too much input. And I think, you know, a lot of these things, it's just their brain, it has their neurons can only handle firing so many things at once. So that's what that absence of visually directed reach means. Let's keep going. So what does treatment look like? Luckily, treatment for CVI, but really visual, helping someone with their vision and how their brain processes vision can happen all day, every day. I hope that as we went through this, I gave you some practical ideas, but school and therapy can make these really simple things. First off, not writing them off or giving up on them and saying, well, they can't do it, but just giving them time and slowing down, making their room, their environment. I know I say school, therapy, and home, but I think that's all become one right now, right? I don't know about you guys, but it's all one right now. So making it all simple and not busy and setting it up for success. And I know that sounds easier said than done right now, because work, home, therapy has all become one. I know it's chaos. And that it's harder to make it quiet and simple while trying to do therapy. I know that's hard right now. I get it. I'm doing that. I understand. But just trying to set them up for success in that way, and the routine, and like these boards here, and when trying to do things. Just again, see that red outline, and whether you take the Toby and you put a red tape around it to direct the attention. It can just be really simple, cheap, easy things that I know a lot of our families have done that allows them to communicate better. A button that families have done, just little things that even just slowing things down can help. And I think that, okay, let me just make sure. Making sure that we do those will help do that. Let's go to the next one. I keep trying to push buttons to change the things. Does it improve? The research that has been done on CVI notes that all patients with CVI get better with purposeful changes, but you have to change everything. You can't just change therapy. You have to make changes at home. You have to make changes at school. You have to make changes everywhere to help set them up for that success. And the brains are, I always want to be like, brains are smart. Like, look at this picture. It's doing math. But they are smart. They're so plastic, especially when they're really young at 1 to 3. But that doesn't mean we don't give up, because you know what? As we get older, we're still smart. You know what? Our brains can still change and make changes. And they are plastic. I mean plastic in the way that they're able to make changes. There's still, you can make new wiring. You can still do things that helps that firing, those neurons fire in a way that works better. And I think that the earlier we help, the better. And so making the referrals, getting the help we need. Let's keep going. All right, so you're thinking, okay, we got problems. Now what do we do? So here's who we work with. So ophthalmology looks at the eyes. Neurology looks at the brain. The problem is you go to the ophthalmologist and they'll be like, eyes look fine. Then you go to the neurologist and they're like, well, brain looks fine, MRI was okay. Or they'll say, you got this problem, but it's an eye problem. Go to your ophthalmologist. So it's a little bit of a dance, and it's a little bit of a process of doing this. Again, some of the steps you can do at home just to help your child, slowing down, doing some of the things, announcing yourself as you walk in the room, asking others to announce themselves. I'm gonna go back a step, sorry, I forgot one idea, is that when picking out an ophthalmologist, which is who I would start with, is you want to make sure that you're picking out an ophthalmologist that treats CVI. There are some, I'm not going to speak disparagingly, but there are some that don't treat CVI and it's not part of their care. So when you call, you want to be like, does your provider treat CVI? Or calling a local, I'll get to that in a second, but a local center for the blind to see who they recommend for treating CVI. Some of the centers for the blind only treat certain ages, so you could maybe go to the centers for the blind and they would be able to treat CVI, but some of them don't, but you could get recommendations from them on who to see in the community. So that would be some of my recommendations for that, for your community. But also asking your ophthalmologist and neurologist to work together as well. Some neurologists could diagnose CVI. Some may say go to your ophthalmologist, and I think it'll be a fine teamwork to get them to work together. And it might not be CVI, it could just be, you know, you're taking a few steps to just get that brain to work a little sharper and do a few things to get it to work to its best on processing your child's vision. And again, moving slowly, showing things slowly, giving them time to look, asking therapists to give time to look, just communicating, hey, could you just slow things down a little bit when you do it with them? You know, and then if they do get a diagnosis of CVI, telling them, hey, you know what? This is where their preferred area of vision is. Telling them to put that in their chart. Could you put in their chart that their preferred area of vision is their upper right area? Or could you put in the chart just the fact that they have CVI? That's just a good step one. I think, you know, at our hospital, I'm really working on asking them to do that, to, if they're admitted, putting up a sign saying they have CVI, and to please announce yourself as you come in the room. Because how scary, I know a lot of you have been admitted, and how quickly those inpatient teams come rushing in. There's a bunch of them, they're all in there, and just how so many of those patients, you know, you'll see them like shut their eyes and shut down because there's just so much going on. Or they'll, even in our outpatient appointments, they'll close their eyes and shut down because there's just too many people coming in. And it's a little overwhelming. And you're in a new place, you're tired, there's a lot of things. But on the inpatient, you can put up a sign and say, you know what, could you announce yourself when you come in? Could you come in? Could you talk to her first? Let her know who you are. Could you tell her what you're doing? These are all things that we should be doing, period, with our children, is that they should be telling them what they're doing beforehand. But these are things we could put up on signs and asking them to do. And I think even in their charts, we could put up saying, these are our final, these are our preferred vision things. Let's go on to the next one. You know, and just I keep saying final reminders, but they're all. You know, any patient with visual challenges, you know, the world is a scary place. It's all fast. It takes them a while to process things, and they're being pushed through the hospital in a wheelchair really quickly, or they're being walked through and they're just trying to work on walking through as quickly as they're trying to process what they're seeing and trying to make their room and their home and everything familiar and simple. Educating their therapists, setting them up for success. There's so many other wonderful CVI presentations out there as well that I linked in my resources. There's videos I linked on YouTube that are really great. Using, you know, your augmentative communication to your advantage. Again, making it simple, even if the pictures have little red outlines on there around them. Decreasing the amount of choices on the pictures. Instead of having a lot, having 2 at a time or having 4 at a time that have different color. You know, there can just be different changes that can be made to make it visually a little easier for their brains to process. And that's all I'm asking, is just a little bit of change that will make big changes for their brains. And then yearly eye exams forever, just reminding that even as they age, they don't really lose that need for that. Next up, just this kind of is the kind of places that, here's what we have in Denver, but these kinds of places, the centers for the blind children, are these kinds of the places where you would want to find referrals if you have concerns. Talk to your providers, your pediatricians, your neurologists, your local Rett centers. But these are the kind of places that you would ask to be referred to, is these kinds of centers. Would be our recommendation. But again, if they only take certain ages, which ours does in our area, we've found, you know, a list of providers that do care for our patients here locally. Next up. And then here are resources. I have great websites here of CVI. And we can go next. And then these ones on the next page are resources on Rett and vision. If you're nerdy and you like to look at some good stuff, We're working on our own stats here at our facility. We are actively working towards, I think, trying to always get away with talking about COVID, but COVID kind of wrecked our research plans this year because it was a little more clinically based research this year, and because we couldn't clinically get into places or be with people really easily this year, our research got a little wrecked. But we are clinically working on being more intentional on getting some more vision knowledge obtained in the next indefinite time. I'm not going to put a timeline, unfortunately, because I don't know what the next year holds for us, but we are working on collecting evidence and numbers on what this number is in our Rett patients and how many of our patients are affected with it. But I can say we are seeing it in our patients, and we're just working hard to educate people and just give tips that are really practical and helpful for families and working with them. And I hope that you have found it a little bit helpful to either spark ideas that you're like, yeah, my kid doesn't have that, and you thought, you know what, maybe there's some things we can do. And if you did have it, just you heard a few things that maybe be a little bit helpful at home. And I hope you can all, if you have any more questions. Oh, I have a few things I was gonna make sure I answered. Questions. I think I answered. Oh, someone else asked about augmentative communication, and I would just period, and I would just say go back and listen to there's some amazing augmentative communication presentations that rettsyndrome.org has offered in the past, and I would go back and listen to those. It wasn't anything to do with vision, but I would recommend going back and listening to those because there's just some amazing ones on that. And I think we can go to the next thing, which was just asking what the questions were, and I can.
Okay, thanks, Tristan. You know what I want to do is, if we're going to go to question and answer right now, I'd like to leave this slide up if I can for resources, because these are some wonderful resources, and I want to make sure, people have a chance to write down the names of these articles. Would that be okay with you?
Yeah.
Okay. Now, I'm sorry, what's that?
I had another page of resources for you.
So let me go down. Let me continue. There's that one, this one. Is there another one?
No, I think that's it.
Okay. Thank you for a wonderful, wonderful presentation. I know more research is coming. I know a lot of researchers who are working on this issue, and we hope to have publications that will come to substantiate the information that you presented today. But I think the things that you talked about, we as parents, those of us who are parents on the webcast today, or therapists or educators, everything you discussed resonates as something we've experienced. The looking away, and looking off, coming back, shutting down, and thank you so much for giving us an orientation as to what that might be about, and some very practical ideas of what we could do over the holidays, even as things slow down and we're at home, and there might be a lot of red up in your house at this time of year, that you could get some ornaments and things to maybe do some activities with. But what I would like to do is go to QA, and I want to ask if you have the list of questions that were pre-submitted, if you want to go through those. I think you addressed most of them in your slides, but if there's any that you want to highlight again, let's do that. And then we have a couple that have come into the question queue.
I think the only other one someone asked about language and comprehension and reading. I mean, I think there's been some in the next list of resources was I think I put the last one is a pilot study of eye tracking with visual processing on the last one there, but I know there's been research done on reading with these kiddos and comprehension. I think the hard part is the eye tracking versus going in, processing, output. And I think it varies between kiddos of what we see. And some have that strong eye gaze. And, and I talked with Tim about this, and I think we see that some kids can do that hard fixation, but is it fixating? Are they fixating because they're attuning to something, or because they're trying to figure out, what am I looking at? And I think that's the hard part of what we don't know, is it because they're like, what trying to attune? Is this, sorry, I keep holding it to that, but it's my easiest, smallest thing. They're trying to attune this from the rest of the environment, or is it because it's a visual appealing to them, or is it, that's the hard part, is what we're trying to decipher. And I don't know how we can decipher that easily. And that's been our debate, I think, in our clinic, is trying to figure out visually how to distinguish that. And I think I answered the other questions. Other one was aging, and I talked about cataracts and the fact that we can still get it. I mean, unfortunately, we're just not they're just not not unable to get all the things that aging comes with, which again could, if they enjoy watching tablets or TV and things like that, that if you want to get glasses, or get glasses that as they age, I think our patients we've seen in their 50s and 60s and 40s, 50s, 60s, is that they still love, we had one that loved watching the Broncos or things like that in her 60s, and if she loves watching her Broncos games, and if for some reason, she was having to sit really close to the TV, then I would say, yes, maybe you should get her some glasses so she doesn't have to sit as close to the TV. Or, if she was moving herself up to the TV to watch it that closely, I would be concerned that her vision, and if you could sit her further back and she was okay with that without getting a little testy, then you would say, okay, maybe her vision was the issue. So I think you just have to watch for behavior, and you guys are the experts in your children. You would know that their vision was bothering them, and that was the thing you needed to treat, if that makes sense.
Great. Thank you. We do have some questions in the queue. Can I read those to you, and we'll see if you've got some answers? Okay. We have a good question from a therapist. And in your opinion, Tristan, do you think there is benefit in slowly working towards visually directed reach, or do you feel you should allow them to process in the way they found works best for them successfully and just leave it at that?
I think that if you're working on their vision, that you would probably see that they're able to do it better over time. But I think that if that's what works for their brains, you also have to, I don't know, I think it's this or that. It's part of it's their brain can only do so many things. And what's the con of them closing their eyes and reaching for something? Is there's not a super con. But I think that the other part is that if you're starting to make changes and small changes in their environment, that their vision will and their brains will start to work in a more efficient manner. And then I think you would see that some of those things change over time. And that's what they see with the CVI research, is that there are changes in some of these things. I mean, again, things have to be simple. Some of these things have to be done, but I think that there's ways that they can do some of these things over time in a way that they can. But to me, that one's, I don't know, would be lower down the totem pole in terms of, like, to me, I would want them to be able to go down the stairs in a safe way by using colors and make sure that their gaze is safe, and I don't know, some of that stuff. But for the ones that can ambulate.
It's a good question, and certainly I know we're all hopeful that as therapeutics come to our children, that pairing these kinds of therapies and working on these things, we might see improvements. So anyway, I think first we need everybody to understand CVI, assess CVI, see what those visual fields are, see what the color schemes are, find the sweet spot for your kids, work on it. And then if you want to introduce some goals to try to improve, to normalize, help them navigate the environment, it's a worthy goal to have. Would that be a fair thing to say? Okay. Tristan, I know the answer to this may not be out there, but there is a question: do all of our children with Rett syndrome, boys and girls, suffer from CVI, or is this something that might be more, less, present, not present in our children?
I think it's probably more, at least in our clinic, we've had probably more the second range, where it's some children absolutely we don't believe have it, and maybe they do and we can't tell in our clinical moments. You know, we see them for such a short time, but from what the parents can tell, from what we can tell in our time, we don't believe they have it. And then there is patients that have it, and then we have everything in between that. Some that you're like, well, they do da 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 da, but it's not super severe. And then you have some on the other end. And so I think it's really the whole spectrum from what we've seen at this point. What we're looking to get over the next X amount of time is our numbers, and figure out from the 200, you know, the amount of patients we've seen in our program, and in which diagnoses, how many have this diagnosis. That's the hard part. Is the other part is we recommend, we'll say in our clinic, we believe you have this, go out and get a diagnosis. They go to an ophthalmologist. The ophthalmologist is not one that, I won't say doesn't believe in it, but isn't one that diagnoses it. And then they'll come back and be like, well, they said we didn't have it. And we're like, well, you obviously have some of the diagnoses of it. So it is a newer diagnosis in the way that it's hard. You can't go somewhere and get a test done for it. You can't just go and get a blood test. You can't go, it's not a clear-cut diagnosis. And so it's a hard thing to get diagnosed with in a way. And so it's been a little tricky for some of our patients to get the official diagnosis. And so that's part of why I say make some changes. It doesn't even hurt for children, period, to have us slow down, talk to them slower, all children, and have us talk to them, treat them slower, show them things slower, use things just in a more simple manner so that they can process them in a better way. If you look through, you know, especially these references on the second page, most of the studies where they're looking at how the brain and MECP2 processes things. All of those all those studies have shown that in Rett, or in I'll keep saying MECP2 changes, is that they do show that the brain is changed in the way that it processes things. So that makes sense that your brain would process your vision in a different way. It might not always be to this total deficit of having all these changes, but it just might mean that it just sends your vision out in a different way or a slower way. And that's okay too. So I think that's, a lot of what I walk away with in this is that, there's no way to not have some kind of vision deficit in the way that your brain is somehow changing it when you have protein changes in your brain in the way that MECP2 changes do.
Okay. Thank you, Tristan. And another question is, could CVI or the processing issue have variability from day to day, right? So our kids have good days and they have bad days. So on a good day, could it be that their CVI is working better versus other days? So should you expect variability and work with that? Any thoughts?
Heck yeah. I don't know. I think, your brain has, I don't mean to keep going back to the brain, but it's such a brain-based disorder, and your brain has slower days and faster days and good days and bad days, and it could be that it's just those neurons are shooting a little faster some days, and it's just an important part of how everything works. And I don't mean to blame it all on that, but it's just it's how everything, it's the most important organ in our body, right? It's got the most protection. It's why it runs everything. And so it makes sense why sometimes your kids can do better in therapy. And they'll do better in therapy some days, and some days they really poop out. There's some days where you're like, you know what, they just cried all day and we don't know why. And then the next day they were fine. And some days they ate really good, and some days they didn't eat really good. And I think that happens A, in all of us, but B, it happens for vision as well. And that makes total sense because and it could be that, you fed it some really good brain food. I don't know. And some days it didn't. There's just so much more good research, I'm sure, to come on the brain, but it's such a complex organ in the way that we're still learning so much about how it operates best, how it works. That's why I work with it, because I think it's the best organ and it's so complex and beautiful. But it has we have a lot to learn about how we can and why we're doing what we're doing, and all this research that you guys are doing. And so much as that is how the MECP2 is processed in the brain and all that. So.
Yeah, I agree. The science is coming, but I don't want any parent to dismiss what to not believe what you're seeing and what you're feeling and what you're observing in your child, right? We hear all the time that sometimes our children seem to do better after a really bad day of seizures, or they might do better when they're feeling a fever. We don't know why that is, but believe it if you see it, and go with it. Tristan, I have a parent is asking just a very practical question: is if they get a referral and they go for CVI testing, what does that look like? Is it something that is a 1-hour appointment? Is it a series of appointments? How long does it take? What does that look like? Do you know?
So it depends on the center and where you end up going. Here at our center, it is a little bit of a longer appointment for that first time, and then they kind of, depending on how it goes and what that looks like, it could be a series of appointments to kind of specialize what it looks like. But those people in the anchor center, in that kind of center for the blind, they're very subspecialized, and those CVI appointments are a little bit longer in their testing for CVI, and it's a series of tests with different very specialized I would say tests. When we were in Italy, we went to a place that did the same exact kind of testing, and it was the same kind of thing. So I'm very secure in that many places across the US, and different countries and different places, are all doing a lot of the same work for CVI in terms of testing for it. And I'm betting in the ophthalmologist appointments, it's a little bit shorter in the way. It's more than just a eye exam in that kind of way. It's not just looking at your eye. It's a series of like colored pamphlet or little book things. It's like a book, and they'll show you this, they'll show you this, they'll show you this, they'll look at this. They're seeing how the child reacts to it. So it's a little bit of a different testing. Depending on the place you go, it's so different place to place, but I would say it's longer than like a 20-minute eye appointment.
Okay, thank you. Thank you very much. And I think, yeah, there will be variability, and just get the process started, and it might even be started through telehealth at this point in time, which, yeah, we'll see how things move and evolve and change as we move through this time. And it could be a number of months that you might be on a wait list. So I think there are fewer experts than there are children in need. So be patient. And again, there's so much practical advice that you have offered that people can start just doing on our own. We are the experts of our own children. So don't wait, give it a try. But we do have a question for you, Tristan, specifically for your clinic, but this may also apply for other centers of excellence. And that is, if you are willing to work with families to help explain this to their educators and other therapists, because sometimes there is a disconnect between what is medical recommendation versus educational and therapeutic application. And I'll put in a plug beyond sharing the link to this recording. Are you available to Zoom in or talk to somebody who might not be quite understanding that this is an issue with their child and wants to get it into their IEP?
Yes, and I would recommend, a lot of these references on the first page at the end of this presentation. There's a lot of really good videos from the people who wrote the books on CVI that have taught me, that I went to their presentations in person, I've listened to their presentations, I've bought their books, that are really the super experts on CVI, and I think will open your team's eyes on CVI, and so I think will be helpful for you. So I think that, but yes, I am available, and we can stick my email in somewhere if needed, but we are available as needed. But I think that once you give them the resources, I think that your team will be like, oh, okay, it's so it's such an aha, I think, for providers, and easy changes like we discussed. I mean, I really think that families and providers and everyone can go, oh, well, that's something we can do and make these changes. And I think, your whole team always wants the best for your child. It's just sometimes seems overwhelming, but some of these changes are such easy ones that the families can make. And thank you for that, Paige.
You're welcome. So I just put your contact email in the chat box. So if anyone wants to contact Tristan with further questions, thank you for offering to share your email address. It's rettclinic@childrenscolorado.org. So Tristan, thank you so very, very much for joining us today. We know that it's been a very difficult year for you, for Dr. Banky, for the entire team at the University of Colorado Children's Hospital, as well as for every healthcare provider and essential worker this year. We know you're exhausted and you're tired, and I hope that giving this presentation today maybe helped you kind of lift you up a little bit, get you refocused on regular work. And I hope for everyone in our audience and that attended today that you learned some things that you can put into practice right now. Give it a try. This is it's a topic where more information will be coming. This is a great start, and we hope to have you back again, and perhaps we will be able to invite a CVI specialist to co-present with you when some of this research does come to publication. And we wish you the best of luck, and I wish you a happy holiday. I hope that you have a chance to rest, restore, refresh, and keep moving on, because we don't know where we would be without you. So
thank
you for being with us today. We are at the close of the hour. If there are more questions, type them in real quickly into the question box, and I will get together with Tristan offline and we'll get them answered, or we will add them to our next presentation on this topic. I would like to just share a couple of quick updates from rettsyndrome.org that I think are important for you to know about. All right, so research is continuing. We have a nice video on the status of research. I think that's really reassuring to know that during this time, a lot of research, although it had some hiccups and some of the clinical trials needed to pause, a lot of other research was able to continue in COVID-safe fashion. So there are, I believe everyone at this point knows that we were able to launch a program on our website called the Rett Research Ready program. And part of that program is a My Rett Trial Finder. And there are a lot of research opportunities that you can participate in. These are 3 that don't require actually participating in a clinical trial, but are super important. And there's QR codes here that you can take a snapshot of to access. A lot of them are related to COVID, and the community is really needing to understand the impact of COVID on you or your family if you tested positive, or just how this experience has affected your access to medical care, therapies, education, and whatnot. So please take the time to add your voice and make sure that our children are considered as we go through this pandemic, but also look at My Rett Trial Finder to find all kinds of research opportunities. The research, as much as we fundraise, as much as we wish and dream and hope, none of it can really advance without our participation. So that's my plug for the My Trial Finder. We are also here for you to empower you with information such as the RettEd today. We have an entire digital library of past RettEds that you can access on our website on many different topics. And we still have available on our website recordings from the Facebook Lives that we ran at the very beginning of the pandemic back in March and April, where we had therapists do live webcams into everyone's homes to demonstrate how we can use everyday objects to do movement and stretches, aqua therapy, communication. All of those resources are still available on our website, and they're really good, and they've had thousands and thousands of views, and the feedback that we have gotten has been incredible as to how helpful it has been to have that look into a real life home with a real life therapist doing a virtual session with a parent, and we have them segmented by young children, teens, tweens, and adults. So please go back. I know we're all short on time, but we are all also spending a lot more time at home, and maybe accessing some of these videos will help give you some ideas of things you can continue to do in your home to develop your child, because we believe in them and we believe in their growth, their development, and we know that with the right resources, you can help really maximize their potential. All right, next month we will be meeting again for RettEd on January 12th, and we will have a research update. It will be at 1 p.m. Eastern, and we're just getting organized to get our whole 2021 calendar posted. But you can count on us through 2021 to continue live monthly updates on the topics that are of importance to you. So as we close out the webcast today, we will ask you to answer a survey. Let us know what you thought of Tristan's information. And let us know if there are any RettEd topics that you would like us to see in the area of research, therapies, education, communication, advocacy, self-care. We believe in all of these domains being attended to, that while we are working for a better tomorrow in accelerating research, we need to take care of ourselves today. And if I can bring an expert to you to help you in any of those areas, it would be our greatest honor to do that for you. So thank you. We hope that you make it through the end of this year. We hope that 2021 brings us all kinds of new opportunities and excitement. Keep hopeful, stay well, wash your hands, wear masks, and we'll be with you again on January 12th. Thank you again. Thank you, Tristan. Thank you for all of us for being a really close-knit community. Nobody cares more about Rett syndrome than we do, and we will keep advocating on your behalf. Until then, we'll talk to you soon. Bye-bye.